Hello, and welcome to the Heart Smart Education class presented by Bronson Cardiac Rehab. Today we'll be going over the anatomy and physiology of the heart, different diseases of the heart, as well as interventions that can be done. But before we get started, I just want you guys to take a quick little second and do some stretches, some light exercises, just to help get that blood flow moving to the body, get that blood flow up to the brain, as well as make sure our body is ready to learn today. So after you've done that, we're going to jump into getting to know our heart. The heart is a very important muscle that is responsible for the flow of blood and oxygen into the body. This allows that blood to go to our muscles, to our brain, to our lungs, to our kidneys, and everywhere else that blood is needed in our body, to all those different tissues. So how does it do this? And the oxygen moving around our body through a combination of muscular tissue as well as an electrical pathway to help stimulate that muscle to work. So as you'll see here, that muscle contracts, which will move our 4 different chambers of the heart. Those chambers are right versus left, as well as atrium versus our ventricles. So after blood gets used by our brain, by our muscles, our kidneys, and all that living tissue within our body, goes back through our vein system to our right atrium. Our right atrium will contract, send it to our right ventricle, and that right ventricle will then contract and send it out to our lungs. You'll see this is the shade of blue, which is going to denote that is deoxygenated blood. When it goes out to our lungs, that's where that gas exchange happens. CO2 goes out, O2 comes back into the blood, and then it will return to our left atrium. Our left atrium will then contract, sending it to our left ventricle. Our left ventricle will then send it out our aorta to the rest of our body to be used up by our brain, our muscles, and all those living tissues as well. A fun fact about the pulmonary system is that the pulmonary artery is the only artery that carries deoxygenated blood, and the pulmonary vein is the only vein that carries oxygenated blood. One way to differentiate arteries from veins is that arteries start with an A, same as the word away, which tells you that it carries blood away from the heart. Fun fact for the day. One thing we talk about is congestive heart failure, or that heart's inability to efficiently move blood through, whether due to the weakening of that heart muscle or the overgrowth of that heart muscle. Over on the left, we see a normal left ventricle. You'll see that pink layer is going to denote the left ventricle muscle layer, as well as that darker red is going to be more the inside of that left ventricle, looking at where that blood actually pools and goes. When it comes to our heart failure, we always look at something called your ejection fraction, or your EF. This is going to help us to determine how well that heart is pumping and in what kind of heart failure you might be in. Your EF, a normal range, is about 55 to 70. So as we look into that middle, or that concentric hypertrophy, also known as heart failure with a preserved EF, that is looking at a person who has an EF of an appropriate range, so in that normal range we talked about, but they don't get enough blood into that heart chamber itself. And a lot of times this is due to a lot of hypertrophy or muscle growth. So that heart is no longer able to relax. Sometimes we call this diastolic heart failure, because diastolic describes that heart phase where that heart muscle is relaxed and filling back up with blood. So in that diastolic heart failure, that blood can no longer pool into that muscle, so we can't get enough blood actually into that chamber. But when we contract, we're still able to get a normal percentage of that blood out. So we look over to the right, we see eccentric hypertrophy, or heart failure with a reduced EF. This is where that heart muscles become so weak that it starts to balloon, and blood can sometimes start to pool in that left ventricle. And because that heart muscle is so weak, when it goes to contract, it can't contract forcefully enough to get that blood out. We also sometimes refer to this as systolic heart failure, because the heart is failing in the systolic phase, or the contraction phase of our heartbeat. So with this, we have that EF is now reduced, sometimes below 30s, into the 20s, and sometimes the teens. So therefore, we can get blood into that heart, but we can no longer get blood out of that heart. And there are a couple different things that can cause either of these to occur. Sometimes it can be due to a blockage, it can be due to a heart attack, can be due to valvular issues and disrupting the flow of blood, as well as different cardiomyopathies or different diseases of that heart muscle itself. About heart failure, we'll also talk about your heart failure zones. These are kind of listed like a stoplight you would see out in traffic. So green, yellow, red. Green means go. This means you're at a good fluid volume. You're not kind of bloated. You're not swollen up. No shortness of breath. No chest discomfort. This means you are good. Just kind of go out and do as you would be doing and just kind of keep an eye on what you're doing to make sure you don't start to develop any of those symptoms. Now next move to yellow or our caution zone. This is kind of where you start to feel some of those symptoms, a little bit of a weight increase, 3 pounds overnight, maybe 5 pounds over the space of a couple days. You're looking at a lot of fluid overload on the body, so you might have some swelling going on your abdomen, maybe your fingers, your toes, your feet, your ankle area, a little bit of a shortness of breath, maybe a cough going on, a little bit of chest discomforts. If you do start to feel these symptoms, it is important that you give your doctor a call. They may do some medication management, maybe some symptom management, or have you come and be seen at the clinic, or maybe even go to the ER. Now, if you're feeling a lot of discomfort, a lot of shortness of breath going on, a lot of chest pains going on, it's really difficult for you to breathe. At this time, you are having a lot of symptoms and potentially a CHF exacerbation. So you should be going seen at the ER so that way they can give you medications to help treat that fluid overload before it comes really bad. So how do they check for CHF and maybe see if things are going that direction? A couple different things they can do. One is a echocardiogram or an echo. This is where they do the ultrasound of the heart and the kind of areas around the heart so they can look at the valves, they can look at the heart muscle, they can look see how that heart chambers are contracting to see if there are any structural issues going on with the heart. Next one is a nuclear stress test. This is where they inject a imaging agent, do a set of pictures, and they give your heart a stress, either pharmacological with the medication or with the treadmill or other exercise equipment. Give you another imaging agent dosage. That way they can see the difference pre to post and how that blood flow is moving through the heart itself. You can do a heart catheterization where they either go through the groin or the radial artery and they can inject a dye directly into the heart and see how much that dye is being pumped out with each beat. And finally, they can do a heart MRI or like a CAT scan of the heart to see the different components of the heart as well as the structural mechanisms associated with the heart itself. So you look for those muscle tissues associated with the heart. Like we said, the heart also has an electrical system associated with it. So as we look here at the electrical system, you'll see over in the left atrium area on the left top side of the heart, we'll see something called your SA node. This is the natural pacemaker for the heart muscle itself. This is where our heartbeats are supposed to originate. From here, it will send that heartbeat down and across to the left atrium, therefore kind of giving that top half of the heart the ability to pump and that signal to pump send blood down to the ventricles. From there, it'll go over to something called the AV node, which is kind of right in the middle of the heart. The AV node's job is to hold that heartbeat just long enough to allow those atrium to contract so that all the blood is down into our ventricles. From there, it will send that signal down through the middle of the ventricles, down to the bottom, and then the contraction will actually start at the bottom of those ventricles and then contract upwards, sending blood either out to our lungs or out to the rest of the body. A lot of different things can actually cause a change in the electrical activity of the heart. A heart attack can lead to a change in that electrical signal. A change in your electrolytes can affect how well those heart muscles are contracting. A permanent pacemaker can actually start that heartbeat either in the SA node up in the atriums, or if it's not working, it can actually start it in the ventricles, as well as an internal or external defibrillator can also lead to a change in those heart muscle rhythms. So as we look here on the right, this is what a normal ECG looks like. This is kind of what we are looking at while you're exercising. If you get all those stickers on you hooked up to the wires, this is what those doctors are looking at. Because we're looking to see how is that heart beating? Is everything beating in the correct order? Is everything beating at the correct intervals? And is there any kind of ischemia potentially going on with the heart? So you'll see that P wave over on the left side of that EKG or ECG. That is the SA node firing. So that is making sure we are in sinus rhythm. It's making sure that SA node, it is starting our heartbeat, and it is making sure that is the pacer of the heart. From there, you'll see the PR segment. This is that AV node holding it. You'll see that beat, making sure all that blood gets out of the atrium down to the ventricles. Then we have our QRS contraction. This is the right side of the heart, immediately followed by the left side of the heart beating. This is one thing we pay a lot of attention to. So this can tell us if that timing is thrown off. So it's something called a bundle branch block or a fascicular block. You can also tell if there's any kind of ischemia potentially going on how that transitions over to that ST segment. And that's that space in between the QRS and our T wave, which is the relaxation of those ventricle muscles. If there's any kind of change in that ST segment, it can tell us if there's a heart attack happening or if there's any ischemia or lack of blood flow going on, because that T wave is that relaxation of the muscle. So we can see how it contracts to relax to see how that muscle is doing. One thing we look at with those ECG readings is to make sure everything is beating in the correct pattern. Things start to get thrown off, it can lead to arrhythmias. So as we kind of look here, over on that left side, the normal heartbeat starts over in the SA node, goes across the atrium, down to the AV node, down to the ventricles, and fires appropriate order, appropriate timing, and everything is moving as it should be. One thing we keep a close eye on is something called atrial fibrillation. You'll kind of notice there are multiple different pacemakers going off, setting off that heartbeat itself. So it's not just originating the SA node, but it's originating all over the atrium. Atrial fibrillation kind of being known as irregularly irregular. So there's no rhyme or reason as to what beats actually get through the AV node and down to that ventricle. So things can kind of feel like they're flip-flopping in your chest. Maybe some shortness of breath with this. But that's one thing where there's very unorganized rhythm going on. So the heart isn't beating appropriately. Things aren't beating at the correct time. Things are just beating. It's very unorganized and very sporadic. Other things we look for are atrial fibrillation. You kind of see that sawtooth pattern going on in between the QRS beats. This is kind of where there's multiple different pacemakers in the heart, but it's a little bit more organized in atrial fibrillation itself. Next one are these big wide beats going on. These are called PVCs, or premature ventricular contractions. These are where that bottom half of the ventricle just gets stimulated again before the SA node actually fires. These are common. Everybody has these. You might feel yours, you might not, but it's just something we keep an eye on to make sure they don't become very frequent or any kind of runs or patterned displays. Another one we see here is that short little narrow beat, or a PAC, or premature atrial contraction. This is where that SA node or something in the atrium gets stimulated and it just fires very quickly. Again, everybody has these. It's just kind of something we keep an eye out to make sure it does not become a problem. And lastly, you'll see these big wide beats. This is called ventricular tachycardia. This is one of the deadly arrhythmias that we keep an eye out for. If you do see this, you're most likely going to be getting hooked up to the crash cart and you'll be meeting a lot of people very quickly, because this is where those ventricles are just taking over and firing very rapidly. This does not allow blood to really fill into those ventricles, so it can decrease and actually stop the flow of blood out to the body. So we want to make sure we can get that out of you as quickly, get you out of that as quickly as possible if we ever see it. So one thing I talked about was a pacemaker or a defibrillator. This is the device a cardiologist can kind of implant into your chest, sometimes over in your rib area. But what it can be done is it can be used to help that heartbeat to make sure everything stays working perfectly. So if you're having issues with the timing of your heartbeats or with things pumping out of order, we can place a pacemaker in there and it can sense to make sure the SA node's firing. If that's not working, it can cause a stimulation to work as the SA node. The AV node is not sending that signal down to the ventricles. We can also send something in there to where it stimulates those ventricles to fire as well. So it can be used as kind of as an insurance policy to make sure that heartbeat is working appropriately. We can also set defibrillators in there. So if you're prone to extreme arrhythmias or potentially deadly arrhythmias, We can send a defibrillator in there to where if it ever senses that arrhythmia, it can send you a little shock. Now, if you do have a defibrillator in your body and you ever feel that shock go off, you should call your doctor as well as go to the ER. So it means it either detected a deadly arrhythmia, you need to be checked out, or that defibrillator is not firing properly and it discharged at the inappropriate time. Either way, you need to be seen to make sure they can investigate it and see what is going on and give you the proper treatment as needed. Another thing we talked about that can be seen on those EKGs are different ischemias or myocardial infarctions potentially, depending on how bad that ischemia or blockage is going on. So the first one we're going to talk about is an STEMI or an ST elevated myocardial infarction. Myocardial infarction is just another name for a heart attack. So if you go to the ER with chest pains, they hook you up to that EKG, they look at that and they see something that looks like this, almost like that tombstone. That's going to tell them that there is a blockage going on that is disrupting the blood flow to the heart muscle. So the heart muscle is not contracting appropriately. So if they see this, you're going to be sent over to the cath lab, get first treatment. They're going to try to go in there and try to open you up and try to make sure they can get blood flow back to that heart muscle. Now if you go in and they see some depression in that ST segment or an NSTEMI, non-ST segment elevated myocardial infarction, having some chest pains, they're going to give you a blood test. For this test, they're looking at something called your troponins. And a troponin is a part of every muscle. So you might be wondering, how do they differentiate heart muscle from more other muscles like our biceps or our quads? So what they can do is they can actually differentiate that heart muscle out with calcium because the troponin is different in our heart compared to the other muscles in our body. They can see how does that troponin level vary over 2 hours. So if you are having a heart attack, that troponin level is going to elevate rapidly because there's going to be more and more damage going on to that heart muscle. So if they see that and they see the other signs, they'll talk to the cardiologist. They'll get the cardiologist input and get you on over to the cath lab if they think you're having an NSTEMI. And so they can go in, find that blockage, and hopefully open you up. So looking at a heart attack or a myocardial infarction, this is when there is that blockage in that coronary arteries disrupting the blood flow down to the heart muscle. So if the heart muscle is no longer getting blood flow, that can start to die off. They can see that change in the electrical activity because the heartbeat is no longer beating correctly, and there's going to be a change in the electrical activity of that heart muscle area. So when they go in, they're going to try to find that blockage, open you up through potentially a heart cath. When it comes to a heart attack, it is important to know your symptoms because your symptoms are going to vary from person to person, but yours are going to be very similar each time. So a lot of times the main symptoms are chest pain or discomfort, or like a pressure or a tightness in the chest. You can get pain in the back, the neck, sometimes that left jaw area, that left arm can start to tingle, get excessive sweating or shortness of breath going on, maybe some nausea and vomiting, or some dizziness. This is all due to lack of blood flow to those areas or disruption of blood flow to those areas from that heart attack. It's also due to referred pain because the heart itself does not have any pain receptors. So it has to find a way to talk to the rest of the body and to the brain to be like, hey, something's not right. We need to get this checked out so we can be fixed. So if you are having a heart attack, the first thing they're going to try to do is do a heart catheterization on you. This is where they're going to pump you full of some bloods, maybe a little bit of anesthetics, as well as some vasodilators, make sure that blood is nice and wide open, some antiplatelet medication, just try to break up any of that clot or any of that blockage going on. And they're going to feed a tube or a cath wire either through your groin or through your arm. They're going to feed this up through your atrial system, back to the aorta, and out to those coronary arteries. From here, they're going to inject a little bit of dye into those arteries, and they're going to see where is that blockage or where is that narrowing going on. They think they are able to put a stent in. They'll place a stent in there over a wire, inflate a balloon to expand that stent and try to open up that blockage to get blood flow back to the heart muscle to make sure it is getting adequate blood flow so we can kind of start beating and kind of get back to being. So here is a picture of a heart cath before and after a stent. So as you'll kind of see in the top left, there is that narrowing of that coronary artery. So they'll go in, they'll put the stent, they'll inflate that stent, let that stent kind of become a structural component of the heart wall, and then they'll put that dye back through, and you'll see nice, smooth, clean heart flow back into that heart artery, down to that heart muscle, allowing that heart muscle to breathe again, getting that oxygenated blood it so very needs. The stent and does not think he can open up that blockage, or if there are multiple blockages going on, or depending on where those blockages are at, one thing they might try to do is a coronary artery bypass grafting, or a CABG procedure. This is where they'll take either a saphenous vein, a radial vein, or use one of those vein arteries that are right there, right off the aorta, and try to open up and kind of sew in underneath that blockage to create a bypass or a new route of that blood flow down to that muscle that is lacking the blood flow. Going on, and they see it as not due to a blockage, it could be due to a heart valve going bad. So the heart has multiple valves in it, separating the different chambers, as well as separating the different ventricles from the tubing or the pathways it is sending that blood through. The heart valves can go bad either due to regurgitation or a leaky heart valve, or due to stenosis, to where there is calcification, so that heart valve either doesn't open up all the way or it doesn't close all the way. So as you'll see over on the right, we have a healthy aortic valve, opens nice and wide, and then when it shuts all the way. This allows the proper amount of blood to come out of that left ventricle to the aorta, as well as doesn't allow that blood to then flow backwards into that left ventricle after it's already been pumped. Now, if the heart valve is stenotic or it has a lot of calcification going on, it won't be able to open up all the way, so that's going to interfere with the amount of blood that can actually get out of that ventricle. And it's not going to be able to close up all the way, so some of that blood that's going to get pumped out is going to come right back into that ventricle and just sit there and pool and put a lot more pressure on that heart valve to work. There are multiple different ways they can fix these heart valves. They can do a heart muscle graft, or a graft of that heart tissue, and put that in there to create a new heart valve. They can use a bovine or a pig heart valve. They can also use cow heart valves, where they can sew those into place. Now, depending on who you are, kind of what your comorbidities are, and kind of your age, and other different diseases you might be dealing with, they might decide to do something called a TAVR, or a transcatheter aortic valve replacement. This is where they can go in with a heart cath procedure, just like we talked about with MIs. They can go in and they can place a new heart valve right where that pre-existing aortic valve is placed. They can inflate that artificial heart valve in there and just let that sit in place so that it will start working. So depending on who you are, how old you are, and kind of different factors associated with you, they might decide to do the open heart procedure or that TAVR procedure for you. So you'll kind of see here are two different types of valve replacements. On the left is more of a mechanical valve, so those flaps open and close with the heartbeat. On the right is more of one of those artificial valves from tissue, so either from a pig or a cow or from other heart tissue. So it's it's not as mechanical, but is more similar to that of your valve that is already in place. Here's just a little bit more about that TAVR procedure. So you'll see that heart valve comes in on the cath wire through the aorta, goes right into place, and it's all folded up and together. Then you'll inflate a balloon inside that heart valve itself, expanding that heart valve so it gets stuck nice and in place where the bad heart valve is. And then they'll pull out that cath wire, and they'll see to make sure that heart is beating perfectly, so when that valve gets used, it's not leaking, it's opening and closing as it should, and it is working properly, so that way it can go ahead and replace that replace that heart valve that is no longer working. I know we talked a lot about the heart, but with the cardiovascular system, there's also something called peripheral artery disease. This is when there's narrowing or blockaging going on in other areas of the body, such as the lower leg, which can lead to discomforts while exercising. The physiology around this is very similar to that of the heart itself. With this, it can lead to pain, cramping, aching, tingly, discomfort when trying to walk or exercise. So the interventions of this can be very similar to that of the heart. They can go in, they can place a stent and just try to open up those valves, just try to open up those arteries in the lower leg. They can also do bypasses where they can take other veins and sew them in around those blockages to allow that blood flow down to that working muscle. Help relieve some of that discomfort and just kind of help you feel better while moving and just kind of allow you to have pain-free motion. And finally, if you do have any questions, feel free to talk to the exercise specialist you are working with at Cardiac Rehab. I hope you enjoyed this presentation and hopefully you were able to get something out of it. Thank you. Bye.